You're watching Baptist Health Resource Live, where our respected experts bring you timely and practical health and wellness information to improve your family's way of life. We're healthcare that cares. This is Resource Live.
Hello, everyone. I'm journalist Nikki Mohan. April is National Minority Health Month, and today we're going to talk about health equity, what it means, and how it affects you. Health equity happens when every person has the opportunity to attain his or her full health potential. Though health indicators such as life expectancy and infant mortality have improved for most Americans, some minorities experience a disproportionate burden of preventable disease, death, and disability when it comes to non-minorities. And social determinants of health have a major impact on people getting the proper health care, things like transportation, education, income, and even access to nutritious foods. Health inequities are reflected in differences in length and quality of life, rates of disease, disability, death, severity of disease, and access to treatment. Well, we have with us today two experts from the Baptist Health family and a Baptist Health patient. We're going to talk about this. We're going to talk about health equity, the importance of screenings, and the disparities that exist across the races and ethnic groups. Time to meet all our panelists. I'd like to welcome Dr. Marcus St. John, Medical Director and Director of the Cardiac Catheterization Lab at Baptist Health's Miami Cardiac and Vascular Institute. And also I heard Doctor of the Year, Dr. Sarah Joseph, our medical oncologist at Baptist Health's Miami Cancer Institute, and author Tamara Rodriguez, health and wellness advocate and one of Baptist Health's partners. Thank you all for being here. It is certainly a pleasure to have this talk with you today. Before we dive into today's subject, I want to remind all our viewers, hey, this is a conversation for you. Please send in your questions and comments throughout the segment. We're here for you and happy to answer any questions that you may have. I'm going to start with Dr. St. John. Dr. St. John, doctors always ask about our family history. But in some minority groups, talking about this very personal information within the family, if they told you about it, because a lot of times people leave the house and you don't know what they had and they don't come home, documenting it and sharing it with a doctor is something they're just not comfortable with. Can you tell us why it's so important to know your medical history and its impact on health equity?
Yes, definitely. So knowing your family's history can help you get a sense of what you need to worry about in your own health and your own life, and sharing that with your physician can help him or her target their advice to you or know when to start certain screenings. It can be a difficult thing to talk about, and it may not be something that comes naturally at the dinner table or on the drive to work. But I think these are the sorts of questions that you should think about and prepare before your doctor's visit, and sort of use that as a way to broach the subject with people who might not otherwise be comfortable with it. Say to them, look, I'm going to see my primary care doctor next week. Do you mind just filling me in on how dad died, or what actually happened to you 20 years ago? Was that a heart attack? Because it's going to help them take care of me better. And I think you can use those types of tools to broach the subject in a non-threatening, non-invasive way, and help the whole family realize that knowing each other's health story can impact your individual health.
Well, you certainly have given us the word. Sounds like you've done this before. Our culture plays a large role in our attitudes about healthcare, certain illnesses, disabilities, and even the existence of some medical conditions. The stigmatization, sorry, can I say that 12 times today? The stigma of illness can affect the kind of care that people receive, even keeping people from seeking treatment. What kind of cultural stigmas have you seen in your years of practice, and what can we do to destigmatize healthcare?
So that is a great question. As an oncologist, we deal with breaking the news of a diagnosis, of the C word that I've been told, cancer. Been dealing with treatment planning, so that involves medications such as chemotherapy. And then at a certain point, we also bring up end-of-life discussions. So the hospice word is used. And I've been very fortunate in my years of training and practice that, I was born and raised in Canada, so I dealt with a socialized healthcare system. My background is from the Caribbean. I went to med school in England. I did training in Brooklyn and now in South Florida. So what this has taught me is a lot of the stigmas with the word cancer, the word chemotherapy, the word hospice really comes, and it really is different cultures. But the way that I've broken down these barriers with, breaking the diagnosis to loved ones, a lot of the times they say, tell us, but don't tell the patient, or don't use the word chemotherapy, or put them in hospice, but don't actually tell them it's hospice. So way that I've overcome this is really just listening. Tell me why it is that you feel that way. Do you have any personal experiences with this? Do you have any family history? What is it that we can do to overcome these barriers? So that's one way that I've seen the stigmas exist with all the different cultures that I've been very fortunate to witness and to be a part of, and then to overcome them and to actually sit down and have a very honest conversation with the patient and family.
You have to see that Awkwafina movie, The Farewell. It's about them not telling the grandmother. It's really great, but it's about everything you just spoke about. I want to go to Tamara Rodriguez now. There are many diseases and illnesses that are preventable, but studies show that disparities exist across gender and race, and that a large subset of the population is not receiving the preventative screenings necessary to catch the disease early on. Tamara, you are a cancer survivor. You can tell us firsthand, how important are these screenings, and what do you think can be done to bridge the health equity gap?
Hi, Nikki. Yes, I totally agree with Dr. Joseph that in our community, and especially in the Black community, we know that there's some socioeconomic factors and also cultural factors that lead us to not feel comfortable saying the word cancer, right? We say C word, or we just say, you know what, God will handle it, or, well, it's going to go away by itself. And to me, I think that the way to make it better is access to information, and having leaders in the community and the public health community to identify and work with leaders in the community to let the community that's underserved know that it's okay, and to give them information that will lead them to say, you know what, better I get that access, better I go and get the screening. I know that my early screening saved my life, right? And I was fortunate to know the importance of early detection. But a lot of people in the community just don't realize the importance. I always say, I had an aunt that, she had a lump, and it was like it looked like a third breast, and she refused to get care, and she passed away. Had she taken early steps, I know that she would have been okay, and she would probably still be here today. So I would say, access to information for the underserved community is key.
Yeah, you're right. You must be related to me, because my mother said, I figured it may be cancer, but I didn't want to bother you. I was like, at what point do you think it wasn't going to bother me?
Right.
Dr. St. John, over the past year, many Americans have put off doctor's visits and even emergency room treatment. At the same time, telemedicine has expanded widely, allowing a convenient time of visiting with your doctor from the comfort of your home. No drive time, no waiting room time. What have you seen in your practice during this pandemic when it comes to office visit and telehealth visits? And when is telehealth appropriate? And when is, an in-person visit better over a telehealth visit?
Yeah, thank you. I want to touch briefly on the emergency room visits going down. And we did see this early in the pandemic, drastic drops in the rates of people coming in with heart attacks and strokes without any obvious reason why the pandemic per se should affect the pathophysiology. And it really came down to people staying at home because they were afraid of seeking the necessary care. So I want to reiterate to our viewers today that it is safe to come to the hospital. All measures are being taken to keep patients safe when they arrive. And you should not stay at home if you're having serious symptoms like chest pain or shortness of breath. The American Heart Association has a great campaign that says, don't die of doubt. So don't stay home. Don't not call the ambulance if you need help. With respect to telehealth, it is a great tool. It's going to be here to stay. We will not ever not have telehealth as part of the way that we can access patients. And it can, I think, if properly deployed, be a bit of an equalizer in some of the access issues that we have, but it does require people to have functioning internets, to have access to devices, to smartphones, and so on. So the disparities won't immediately vanish, but as a country and as a nation, we have to make sure that everyone is going to have access to telehealth. The answer to the question, who is right for telehealth? So it is not well suited for serious or potentially serious complaints, or for people who really don't feel well. So for very often new evaluations, especially to a specialty like mine, cardiologist, for a totally new patient, that person is usually better served coming to the doctor's office where he or she can perform a physical exam, listen to the heart and lungs, do an EKG. People who are having chest pain or shortness of breath that seems to be more than just a run-of-the-mill cold or other type of symptom like that should probably come in. Telehealth is great for more routine follow-up, a follow-up of lab work, a 6-month follow-up to check on cholesterol and blood pressure, especially if patients have a blood pressure cuff at home. Those are the types of visits that lend themselves very well to telehealth and probably will be here to stay forever.
I have high blood pressure. I take it twice a day. I'm sitting here diagnosing. You'd hate me as a patient because I Google Doc all my diagnosis and then say, this is what I have. But no, all great advice, Dr. St. John.
Okay, it's great patient. Don't worry about it.
Tamara, primary care doctors are very involved in their patients' overall health. They treat minor illnesses, refer you to specialists, recommend appropriate preventative care, and help you manage chronic conditions like my high blood pressure or diabetes, which is rampant in my family. They are really the quarterback of your healthcare team. What role has your primary care doctor played in your life and your diagnosis? You said you believe you caught it early and that was the reason you're doing so well. How important do you feel your primary care doctor and doctors in general are to keeping us on top of our health?
So I think for me, doctors in general need to be honest and need to be an advocate with you, right? So you need that relationship. And I've been very lucky to have an extraordinary team at Baptist. So my oncologist and I feel that she's always been transparent with me. I think she's always given me the right information or has directed me to finding out where, the solutions for my care. So I'm very grateful for that. I would say in my case, I've thankfully past the 5-year mark. So it's really time to start seeing other specialists, because I hope the other doctors would agree that there's other organs, right? So I can't just kind of stay with my oncologist. I need to go see different specialists and the primary doctor that will refer me to these specialists. So in my case, my oncologist has been, literally has saved my life. Because of her honesty, because of her, listening to how I feel. Because sometimes, you feel a certain way and you have doctors that say, oh, don't worry, it's okay, don't worry. But to have someone that wants to be in that journey with you is something very special. And I'm lucky to have found a team at Baptist that wants to go through this journey and that genuinely cares. So I would say that critical to have a primary doctor, critical to establish those relationships so that you go on this journey with them,
Yeah, and I know, and it helps that you feel connected to your doctor. I'm looking at this panel, it's very representative of our community and at Baptist Health in general, and that makes a big difference. Dr. Joseph, although cancer incidence and mortality overall are declining in the United States, which is great to hear, certain groups continue to be at increased risk of developing or dying from particular cancers, whether it's related to social, environmental, or economic disadvantages. These groups bear a disproportionate burden of cancer compared with others. What kind of disparities really exist when it comes to cancer? What are the facts?
Sure. So I think that's a great question, and Tamara chimed in on that in her previous question. So cancer disparities in the terms of, rate of diagnosis. So like you mentioned, overall, the incidence is going down, but in certain subgroups, Hispanics and African Americans, it's not going down. So 1 in 3 African Americans are diagnosed. 1 in 5 actually die of their disease. And it's because when they're diagnosed at a more advanced stage. So we have a higher death rate and a shorter survival when it comes to African Americans. And just the rate of diagnosis in certain solid tumors, for example, prostate cancer, lung cancer, are higher in African Americans. And breast cancer, for example, are higher in African Americans. And why is that? Because when we look at prostate cancer, we look at lung cancer, we look at breast cancer, these can be preventable. And Tamara was great that she mentioned that we need leaders in our society. We need to educate the public. We need to notify them that, listen, we have screening. If you're a smoker, you have a long history of smoking, we can do CT scans. We can follow that up, check lung nodules. We can follow that, for 6 months at a year until they start getting bigger. We can prevent it if it actually turns into a malignancy. For example, colon cancer. A lot of our patients, they come in at an advanced stage. So I currently have a patient that's admitted. He's in his 70s, he's African American, and he is at advanced stage. So he came in with a stage 4.
Wow.
And I couldn't even treat him because he has a large bowel obstruction. He's cachectic, he hasn't been eating. And, our population, African Americans and Hispanics, screening is at age 45. The general population is age 50 to do screening colonoscopies.
I mean, if Black Panther can die, you know what I mean? You're like Chadwick Boseman has shocked the world.
Correct. So I really think the disparities comes with not having insurance. That's one big thing. Not being educated, not having access to healthcare. And so if we, kind of to put, telemedicine and leaders into this healthcare disparity is if patients have cell phones, we can reach out and call them. That's one way to do telemedicine. If they don't want to come into the institution, we can just call and say, hey, these are the services. This is what we're recommending based on your age group. For example, cervical cancer, we have a vaccine, we have Gardasil. So are you of the age group of getting, Gardasil? I got Gardasil when I was in my 20s, so it's been something that it's a lack of awareness, it's lack of education, and it's something that we can change. We have solutions and we can do it. And I know, being an inpatient oncologist, and I have a GI clinic in the office, we apply for financial assistance for patients that don't have insurance. So there are ways around that we can try helping patients. And, it's just really putting together a task force to say, okay, what are the needs of the community and how do we do that? So
That's
I think
awesome to hear, because so many people worry. They say, well, it's too expensive. I say, well, can you afford to die?
Correct.
Can I still get Gardasil? I know I'm thinking of it for my teenage daughter, but I guess I'm too old.
Well, you know what? So technically the age is 26, but there is some data for less than 45.
I still can't get it.
So maybe.
I'm a goner. Thanks, Dr. The doctors say, John, heart disease. I got to worry about this too because I have high blood pressure. Heart disease is the leading cause of death in the United States, and the risk of heart disease death differs by race and ethnicity. The U.S. African American population have a greater burden of cardiovascular events. Can we talk about the factors that lead to this disparity?
Yeah. Absolutely. I would say ditto to everything Dr. Joseph just said. And I think, cancer and heart disease are different, obviously, but all of the things that she said that contribute to late diagnosis and shortened life expectancy upon diagnosis can apply. I think one of the ways to answer this question is to quickly tick through what are the risk factors for heart disease. And what I tell my patients every day is a risk factor is simply anything that increases the likelihood or the chance that you get a particular disease. So as you mentioned, high blood pressure, high cholesterol, smoking, diabetes, sedentary lifestyle, family history, which we touched on already. These are some of the main risk factors. There are others and some less common. Each of those things, or many of them, not each of them, are things that you have to measure. So what I tell patients every day, you just can't know what your blood pressure is without measuring it. You simply can't guess what your cholesterol is. So you really have to know your numbers. And that's a mantra that we try to tell patients. You have to have some way of finding out what your blood pressure is and then interfacing with someone in the healthcare profession to help you make sense of that. So one of the things that is likely contributing to African Americans having disproportionately high rates of heart attacks, stroke, heart failure, is that they often do not have access to healthcare where they can know their numbers. There's often a distrust of the medical establishment for historical reasons. They often live in areas that are sort of nutritious food deserts where they don't have easy access to fruits and vegetables or safe places to exercise. These are some of the types of things, the lack of insurance that Dr. Joseph mentioned. And then fairly far down the list, maybe in some instances, some genetic predispositions. There's some sense that African Americans may be more likely to have salt-sensitive hypertension. In medical school, one of the things we often learned was one of the risk factors for many disease was being Black. And I often question that. Is it really that there's something genetic about being Black that was causing these things, or is it all of these other things that Dr. Joseph and I have talked about? And And I think the answer to that question is probably a big part of it is just the socioeconomic status that many of our patients live in, not just Black, but disproportionately minority patients.
But does research matter? Does more research need to be done on people of color and how these diseases affect us?
Absolutely. If you have a research study with 10,000 people and 1% of those 10,000 is white, can you really apply that to the Black woman in front of you? And 1% was Black and none were female. So absolutely. So we do need to make sure that the treatments that we use can be broadly applied. And there's increasing efforts to do that. And many of the physiologic basis of drug treatments are likely equivalent across genders and races, but we often don't know that for sure. And there are some targeted therapies in heart failure and perhaps in oncology, I'm not sure, that are specific to race. So research is paramount. The ability to involve African-American and other minorities in research is important, but that takes a level of trust that is going to continue to take effort and dialogue.
And we're going to continue to do it. I feel empowering people with information the way we're doing now is so key. Tamara, vaccines. Let's talk about vaccines. It's all like, it's my first thing now. It's like, hi, nice to meet you. Are you vaccinated? That's what I say now. Right. Vaccines have become a common topic with the ongoing pandemic. You recently got your COVID-19 vaccine. Kudos to you. I'm halfway there. But vaccinations prevent other illnesses as well. And they're always important, especially for those with immune deficiencies like yourself. You know, how important are vaccines for the immunocompromised and staying on top of your upcoming vaccines? How can that help you bridge the health equity gap?
So yes, I was very happy to take the vaccine, and for me, it was a no-brainer. But I do know that there's a lot of people, particularly in the Black community, that say no, they're not going to take it. And when you ask them, why, they really can't pinpoint. And I agree with Dr. St. John that a lot of it is just trust, right? And a lot of it is cultural, meaning that they just do not feel that it's trustworthy. They don't feel that the system is on their side. Right. And that's why I feel the importance of having leaders in the community stand up and speak up so that they can relate, so that community can relate. I met a couple of people that said, I wasn't sure, but then I saw Michelle Obama take it. And then if she can take it, then I'll take it. So that's a testament to the importance of leaders in our community to speak up and to serve as examples. So to answer your question, it's critical, again, the access of information, right? If you're Black, you're at a higher risk. If you're Black, there's underlying conditions that we don't even realize are higher than other communities. So again, for me, I think it's the access of information. And I think we have to consider the cultural factor as a reason why this community, particularly the Black community and the Hispanic community, is so resistant to taking the vaccine.
Yeah, and I've had to deal with people in my own family. And after going through cancer with my mom, I saw how important it was to take charge of my own health. And I talk about scream it from the mountaintop, maybe a little too much, but I do scream it from the mountaintop. Before we take some questions from our Facebook viewers, I want to remind everyone that Baptist Health is committed to improving the health and wellness of our community. Baptist Health offers educational and free programs, free 99, I like that number, health screening, signature events, and access to several support groups throughout Miami-Dade, Broward, and Monroe counties. They include exercise classes like Zumba and yoga and educational programs on nutrition and mental health. For a full schedule of Community Health Department education programs and exercise classes, you can request to be added to our mailing list by sending an email to programs@baptisthealth.net. You can also visit events.baptisthealth.net for more information. We're going to go ahead and take some questions from our Facebook folks. We're talking healthcare disparities. We talk a lot about Black maternal mortality. Full disclosure, I was one of those people. I had a baby, and had I been in the dark ages, I'd be dead, because the amount of care I had to have. I stayed in the hospital 2 weeks after I had my daughter. And at a certain point in time, they didn't think I was going to make it. But I was fortunate to have great healthcare. Why is there still Black maternal health disparities, and why is it happening? Who wants to take it? I'm going to go to Dr. St. John, because at first they thought I had a cardiac issue, which we know cardiac issues can appear after you have a baby.
Yeah, no, I think we don't know fully what the issues are. Some of it has to do with lack of or decreased rates of adequate prenatal care that may be prevalent in the minority and Black community for all of the reasons Dr. Joseph and I have stated: distrust, access, transportation issues, lack of insurance, cost of care, these types of things. So I think if you arrive sort of to deliver and go through that process without having had any type of care leading up to it, your rates of difficulty are going to be greater. And I think that is probably one of the big factors. One of the things that we also battle in cardiology in particular, not specific to maternal mortality, but there may be some overlap, is patients not being heard equally. So women for a long time have not been treated as aggressively for heart disease because we assumed it was just in their head, or, well, you're not really.
My doctor told me I had mastitis.
Having these symptoms. And I think there may still be some of that structural and unconscious bias in the care of mothers who have just delivered. There may be other issues, and again, this is a little bit out of my scope of expertise, but those are some of the things that are likely at play.
Don't all you guys have to deliver a baby in residency, though? I mean, doesn't it happen at one point?
It was a long time ago.
Doctor, you can do it. It's like riding a bike, right? Dr. Joseph, could the speed at which the COVID vaccine was created feed into this hesitancy? I mean, you can't ignore all that stuff going on this week with J&J, but I follow the science. I mean, they think it's fast, but a lot of the science had been there from before, correct?
Correct. So a lot of the times vaccines take years to make. That goes without saying. But with the amount of patients that were included in the clinical trials of Pfizer, Moderna, Johnson & Johnson, AstraZeneca, it is hundreds of thousands of patients. So that available scientific data that came out with the COVID-19 vaccine has shown to be safe and effective. So to answer the question, it is quicker than most vaccines that we've seen in the past. However, when you look at the sheer power of the study, meaning the amount of the accrual of patients, it is very similar to the previous vaccinations that we've seen.
Yeah, well, we're going to wrap up. It's been a great conversation. I would like to continue to use you guys as my personal telehealth visit, but we're going to have to wrap it up. Any closing thoughts from any of our panelists? Feel free. Tamara.
So I think that what we're doing today is part of the solution. Talking, sharing, listening. This is what we need in our community, and we need the public health system to partner with community leaders to continue to engage the patients and engage our community so that they understand the importance of getting vaccinated. They understand the importance of early detection and screening. So for me, I think what we are doing is part of the solution, continuing the conversation.
Dr. St. John?
I would add to that, and I would piggyback on one of the comments Tamara made, that I think those of us in a position to influence others have a responsibility to do so responsibly. And I was reminded of a nurse, an African-American nurse at the hospital who I interacted with a few weeks ago, and she had expressed to me some hesitancy about getting the vaccine. And I told her in very clear terms that she absolutely should get it. And a week or so afterwards, she said, "Doc, I got the vaccine because of you." And I think it reminded me of the influence that we have. And with that influence, Dr. Joseph, myself, spokespeople like yourself, comes responsibility. So we have to act responsibly and educate our communities because they look to us for guidance on what to do.
Absolutely. Dr. Joseph.
So I think the underlying theme is really communication and really education. So we are available whenever we need anything that the community needs, talks, I can give you my email address. We're always going to have an open book, an open door policy that, there's no question that is too small, and we're always going to be available to the community to help.
Absolutely. And I can see that all of us walk with the same feeling. It's not a burden. It's a responsibility. It's a purpose. We're happy to have all the access we do, but we don't want to be here alone. We want to transform our communities. Thank you so much. It has been awesome. For those that are tuning in, viewers, remember you can connect with us always on our social media channels, Facebook, Instagram, Twitter, LinkedIn, and check out our resource blog for the latest news at baptisthealth.net/news. You'll find a link there to all the episodes of the Baptist Health Talk podcast as well. On behalf of everyone at Baptist Health, we ask you to please stay safe and do your part to stop the spread of COVID-19. Mask up, South Florida.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Resource Live is brought to you by Baptist Health South Florida, healthcare that cares.